Huge pleasure to introduce an orthopedic speaker, not something I, the orthopedic surgeon, get to do very often. I'd like to introduce David Feldman, who's Associate Director of the Paley Institute with a special emphasis on hip, spine, and MHE. So here we are, multiple hereditary exostoses. Thank you so much for being with us today, Dr. Feldman.
Well, thank you for having me, and thanks everybody for taking time during your day or night or wherever you are to hear this talk, which I will share with you now. And certainly I know we have times I have to thank both Dr. Tosi, Charlene Waldman, Michael Stewart, Sarah Ziegler, really for allowing me to come today and to give this talk, something that I really do consider myself passionate about. So I will share my screen and hopefully our technology will be effective. Okay, so what I'm going to speak about is a little bit, I know many of you are not orthopedic surgeons, and I will try not to spend this emphasis too much on orthopedics, but multiple hereditary exostosis is mostly a skeletal disease, although there are some behavioral issues with that, but I won't spend too much time on the behavioral issues of the children or adults who have MHE. And MHE affects almost the entire skeleton of patients, and every patient has a different tumor load. And I'm not sure how well this picture comes about, but you see the patient leaning to the side, has multiple tumors through both of the tops of the femurs, distal femurs, proximal tibias, some deformity of all the bones, and really had a very large tumor load. And this is just to show a hip where literally this tumor has gone so large in this 14-year-old, it involved the entire neurovascular bundle of the lower extremity, and it come off the femoral neck, which is here, and all the way across, almost into the groin of this patient, and quite painful and limited the motion. And you can see on this reconstruction of a CAT scan how tumors can be exceedingly large at times and benign, even though they're so large, but they're not benign in the problems that they cause the patients. And this was a patient who went through multiple surgeries to straighten her leg, fix her hips, and a year later, she had straight legs and went back to her town where she lived in the United States. And I'll try to show some cases specifically of how we would treat different parts of this. The genetics of MHE is well understood now, mostly because of the MHE Foundation and the research they have done in elucidating the EXT1 and EXT2 gene, which is a gene that basically is involved in the production of heparan sulfate, and the defect in this production causes the phenotypic response of multiple hereditary exostosis. It's a rare disease. About 1 in 50,000 individuals suffer from this, and about 10% of cases that we see are new mutations. I will say that in our series, about 15% of patients do not either have EXT1 or EXT2, but are probably have a gene somewhere in this region, and sometimes it can be elucidated. So I will discuss the orthopedic issues seen in MHE and try to go through them. So when I meet any new patient who has multiple hereditary exostosis, whether they're young or adults, I say, what can these osteochondromas cause? Well, they can cause impingement, or they can involve getting stuck on a muscle or a tendon or a ligament. They can compress nerves and cause pain, or actually numbness, sensory loss, or weakness. They can cause a joint to actually dislocate or subluxate, partially dislocate, both of the elbow and of other joints as well, of the hip. It can limit the joint motion, like you saw in that young woman with that hip large osteochondroma. I've seen patients with chest pain from this, like pleuritic chest pain, because their osteochondroma involves their lung. And even with chest pain of cardiac of origin, if it hits the pericardium. Spinal involvement is not rare, but probably not as common as most articles think it is. And we'll talk about malignant transformation. What is the chance that someone with MHE will have a malignancy, and is that malignancy serious, or is it something that we can deal with relatively easily? So these are the questions we'll discuss as we go through what multiple hereditary exostosis causes and how it causes it. So how can it impinge on a muscle, tendon, or ligament? Well, this is very common behind the knee, where it gets stuck on the hamstrings, either from a posterior femur osteochondroma or on the inside of the tibia, getting involved where the tendons insert onto the pes tendons. You can have one pressing against the posterior tibial tendon on the bottom of the ankle, just above the ankle, where it involves the posterior tibial tendon. Forearm tendons can snap as patients try to do things. The thigh can snap as it hits the iliotibial band. And the pes tendon, as I said, as they attach to the tibia, can cause pain. But what about nerve pain? And this is, so pain in general, what I would like to say, and I can show some data later, but is that pain is not inevitable in the life of a patient with MHE. It can be treated. So it's not inevitable that they'll have chronic pain. So there are some articles by Dr. Yamaguchi particularly talking about in knockout mice that MHE knockout mice will resist heat quicker or jump off the hot plate quicker than non-MHE mice. And this sort of was conclusion that MHE patients have less tolerance to pain. And that has caused a real problem, in my opinion, on treating patients with MHE, because I don't think it's true. I think MHE patients, when they have pain, they refer to it maybe sometimes in a different way because of some behavioral issues or communication issues, but their pain can be treated and they don't have to live in chronic pain or be sent to chronic pain clinics, which give them medications as opposed to treating the cause of the pain. So in terms of nerve pain, the perineal nerve behind the knee is the most common area that we see, and up to 30% of patients, and trying to get a paper published on this, I've presented this data before, talking about the 30% of patients with MHE can be treated by basically decompressing the perineal nerve and removing that osteochondroma. The saphenous nerve on the inside of the thigh, just above the knee, can cause sensory pain and can be treated. The sciatic nerve behind the hip, much less common. The radial nerve of the forearm, not so uncommon. And the Oden and median nerve as they exit the axilla, like in this case where you see the patient has these proximal humeral osteochondromas, which can hit a nerve as it exits the axilla or the armpit and basically can cause nerve pain down the arm. And all these things can cause weakness or pain or sensory changes in the patient and can be treated by decompressing nerves away from the tumor and removing the osteochondroma. This just shows a drawing from Springer Verlag from a textbook article showing the common perineal nerve coming around the fibular neck, where if there's an osteochondroma can hit it, showing that it enters into the lateral compartment, it can be compressed, showing as it enters into the anterior compartment, it can be compressed. So when I release the perineal nerve, which is every single week, at least 3 times, basically I release it behind the knee, I take off the tumors of the proximal fibula, I release it as it enters into the anterior compartment, and to the lateral compartment, and then cutting this, what's called the transverse ligament, until it releases the perineal nerve. And that works. That is absolutely beneficial for these patients. Just showing a case. Just to orient everybody, this is going to be the thigh coming up this way, coming to your left. The nerve is right here. If you could, can everybody see my arrow? Shake your head, Sarah, if you could see my arrow. Okay, good. And basically, this is the nerve coming around, the perineal nerve, as it enters into the lateral compartment. This is the musculature of the peroneus brevis and longus. And here we have a tumor hitting the nerve. So it's released a little bit behind the knee, and then as it enters into the anterior compartment, and then I retract this nerve anteriorly and will take this tumor out. That is a case where this patient did have a drop foot before I ever treated them, and the drop foot resolved. So that's a drop foot is when you can't lift up your foot because the motor branch of the perineal nerve is not working. And we could talk about what symptoms you see before you get a drop foot, such as top of the foot pain at night, symptoms of decreased sensation in the first web space on that side. And then we release the fascia all the way across and that ligament that I showed in the diagram. And the nerve is then free and the patient is better. Limb deformity is quite common in osteochondroma in MHE. We don't know exactly why. We know that the tumors can cause an increase or decrease of bone growth, but I can't really say that a tumor in a certain area will cause deformity per se. And I've certainly looked at this. Ulnar bowing is a big problem because it causes the radial head to pop out, and I will show cases of that and how important this is to save the forearm. And particularly when there's a two-bone limb, such as the tibia and the fibula, the radius and the ulna, they don't grow symmetrically. And so because of that, you end up with wrist problems, elbow problems, ankle problems, knee problems, because of this differential growth when you have a two-bone area of your body. So you can see this would be genu valgum or knock knees, and you can see that this patient can be treated with modifying their growth. That doesn't matter for this talk how we would treat this exactly. What matters more is knock knees are painful after a while because they put so much force on the outside of the knee. They're also unsightly and they don't have to be lived with. And we treated this case with a growth modulation called an O plate or an A plate. It doesn't really matter what it's called. Treat the ankles the same way, and the bone and the legs straightened out. Now, something happened in this case as the bone straightened slowly, the nerve got impinged around an osteochondroma on the fibula, and the patient developed a drop foot after about 3 months of having this plate in. So things can affect one another. And that's him showing the leg being straight and it afterwards. What about, so I just showed you valgus, but what about impingement? Well, you could imagine that if this is the hip joint and you're trying to flex the hip, this looks like Mount Vesuvius. If your Mount Vesuvius is going to hit the front of your pelvis, you're going to have pain and you're going to have limitation of motion as you flex your hip. And these are also painful because it's right on the flexors of the hip. So these anterior or front osteochondromas of the hip are often quite painful. And here's a patient with multiple osteochondromas around their entire joints of their hips. And the only way to really get this hip to be normal is to dislocate it. So we do what's called a surgical dislocation of the hip. For the non-surgeons out there, this is the femoral head. This is all osteochondromas. And almost 300, about 200 and, let's call it 300 degrees, they can be excised safely off of the femoral head to give it motion, to decrease pain, to decrease arthritis in the future, and really give patients normal hips at the end. Here you can get a really good example of how much of this should all be gone. All of this should not be here. That should just be like a concave, like a timer, like a little sand timer that looks, as you look at it, having a very nice waist here and here, and instead it has this big glob of osteochondromas. And these are benign. They're not malignant. They're just not benign to the patient. And that's after excision. You can see I took them all off, and then I'll put bone wax on this to prevent the bleeding, and they don't come back, certainly when they're finished growing. There's bone wax to prevent bleeding. I protect it by putting a screw up the neck so the femoral neck doesn't break. And there's the patient afterwards with really what looks like almost a normal hip. I can't say it's normal, but it certainly is good. This screw is quite important because the people with MHC do get osteoporosis, and I've weakened the neck by doing all that excision, and then the other side was done later. So the natural history of not treating this is a disaster because these tumors cause the hip to sublux. It doesn't grow normally. And the patients get arthritis and will need hip replacements at a very young age. Somewhere between their 30s to 50s, they will need hip replacements. And it's very difficult to do a hip replacement, which my partner does, not me, in these cases. So we like to treat this early on, somewhere to get these treated so before they develop arthritis, deep in the socket if we have to, and make the hips more normal. Speaking of having both bones of your ankle, not growing at the same rate. So in this case, this looks like severe pronation, right? The ankle is going out to outside the body. This can be quite painful for patients, actually. And the ankle can actually dislocate or at least subluxate, partially dislocate. And this is after treatment. And the reason this happened is because the outside bone, the fibula, is short. So it's not supporting the ankle. It's not supporting the ankle as it comes out, as the ankle wants to come out. So by creating a normal relationship of the ankle, we can actually create a normal ankle for this patient. How we do that depends on the age of the patient. So I said before, two bone area is the most problematic, ankle as well as forearm. So there's many problems in the ankle, and these are them: valgus, which is pronation, the interosseous, the osteochondroma either coming off the fibula or the tibia, separating the two. Short fibula is a very big problem, and therefore the ankle mortise disruption, and a combination of all of the above is important. So here's a patient who was treated with an attempt, but you can see this is not normal. There shouldn't be this wide space of an ankle. This bone should be here, and this should not be round like this. So, and she has here, she can see this bone, the fibula is being eroded. The fibula should be down here. This line should be here, and this is the same. The fibula should be down here, but this joint looks more normal to me. So in both cases, I did two different things, but I had to create the relationship of the tibia and the fibula to be normal with each other. So I had to shorten the tibia in this case. So I supported the fibula, and then shorten the tibia so that I could actually restore the ankle joint on both sides. Same thing. And so that's what it looks like before and after. Same thing, before and after. The forearm is a big problem, and this is my soapbox for MHE, is that we shouldn't just let joints dislocate. This young man, his radial head dislocated, and it didn't have to dislocate. It could have been prevented. This is after I treated it, but it didn't have to look like this ever, because once this happens, the motion will always be a problem. So there's two things that happen in MHE forearms. One is the wrist becomes slack because the slope of the radius becomes large. So the wrist becomes weak, where your grip becomes weak. The ulna being short and bowed is a problem. Bowing is the biggest problem because it pushes the radial head out, like when we treat Montesia elbow fractures. So this is the radial head, and actually it can dislocate out, and then you can't turn your arm, supinate and pronate your arm. And it's also cosmetically displeasing and functionally displeasing. So you can see it's starting to come out. It's subluxing because of this bow. This is limiting motion. This is causing the wrist to be slack. And you can treat all three problems. You shouldn't have to wait until it's fully dislocated, like in this case, which is much more difficult to treat, which is here me treating it, but still it's much more difficult to treat. And these are just cases showing how you can straighten the ulna, straighten the radius, and make these patients quite functional, both cosmetically and functionally for use. So spinal involvement or spinal problems. So the spine is likely involved up to 30% of patients with MHE. Now, the articles say that 20% of those patients will require intervention. That's probably not true. I think that it's probably much less than that, but it has to be followed. You need to get CAT scans or MRIs, because if there's an osteochondroma sitting in the canal of the cervical cord, the patient can have acute paralysis. So, something like this could cause pain, but not paralysis. Here's a tumor off of the spinous process, not involving the spinal cord. But we need to look for, I get MRIs on all my patients, usually before the age of 6, to see their spine. So it can involve any part of the spine. It most frequently grows off of these areas of the anatomy. And I do look for, like in this case, when it's pressing up on C1. This cannot be observed. So this patient was told to just be observed. This is at the level, here we have a level of 1, 2, 3, 4, C5. Here I have a level of C1 and 2. So basically, the symptom of this patient will be actually death. This patient will just basically probably become apneic and die in their sleep. So we can't wait for this to happen. We get MRIs, we check them. This patient had very little symptoms of this before I took it out, and I was able to take it out quite simply. And they can be quite large as well. Okay, this is a very common problem is of scapula, the shoulder blade. And this is a really good picture of showing them, because your shoulder blade goes up and down on your ribs on the inside of it as you raise and lower your arm. If you have an osteochondroma sticking out, it acts like a pick on a guitar string. and actually it plays guitar on your ribs. And that can be quite painful and dysfunctional and very easy to remove as well. So they don't have to have pain. And the rib ones that are internal can involve, as I said before, chest pain or lung pain. And here's one that could cause, breath. This was causing the patient pain when they did activities, when they inhaled and exhaled. And you can see how this is pressing up against the lung. So pleuritic chest pain is pretty painful. So meaning that the pleura of the chest, if it's being compressed, it will become pretty painful. I'm sorry, that's actually the liver it's pressing up against, but the lung is coming down. And here's the lung, I'm sorry about before. But basically, this was one that was actually pressing up against the pericardium. Okay, I'm going to stop with this part. The next part is malignant transformation, because everybody wants to know about that. That's actually an important factor. So I did a literature search or a beta analysis of all the deaths from MHE, from chondrosarcoma, which is the sarcoma we get from an osteochondroma. It almost always occurs in adults. It's almost always very, very low grade. And can be excised marginally, which means you don't have to take out tissue with it. And I only found one death secondary to this osteochondroma or chondrosarcoma in a patient who was ignored for 22 years after presenting. So these can be treated, even if they become malignant. Sometimes it's difficult to tell, for a pathologist to tell the difference between a grade 1 chondrosarcoma and an osteochondroma, but certainly in an adult, if this is growing in this cauliflower nature of this tumor, and we know about cartilage cap being more than 10 millimeters or so on the MRI, then we think it's malignant. Either way, these can be excised and almost always will be benign or low-grade chondrosarcomas. And we rely on the fact that it's growing or becoming painful as an adult to rely on taking this out, or this radiologic appearance also helps you. Certainly if there's a soft tissue component where one of these breaks off as in growing in the soft tissues, that's a grade 1 chondrosarcoma. And again, these can be excised. So I think the conclusion of this, to make lives better and improve quality for the lives of our patients, is appropriate surgical intervention can prevent chronic pain, joint dislocations, limitation of motion, arthritis, and nerve complaints that we see in adults with MHE. And we will be presenting data on all this, over the next year, hopefully, where I've presented a lot of these papers on the ankle and the hip and the forearm, but hopefully it will come out within published papers within the next year as we submit them. So I look forward to showing cases and taking questions. I stayed within my time frames. We have plenty of time to answer questions that you may have about this condition. And thank you for listening.